Good morning, everyone. I'd like to call this public hearing of the Senate Institutional Sustainability and Innovation Committee to order. Today, the committee will be discussing hospital sustainability in Pennsylvania. We all remember 5 years ago, in the depths of battling COVID, the COVID pandemic, our hospitals and our first responders were the healthcare heroes on the front line of that battle. Now, 5 years later, our hospitals are suffering from financial instability, a lack of stable and consistent workforce, closures, consolidations, and looming in the future, some updated hospital regulations. Investment from private equity companies is at the forefront of this discussion as well, which, given the situation with Crozier, and the chairman to my left will be speaking to that in a few moments, I'm sure, the ripple effect of that closure is going to have a significant impact in the Delaware County region. But we're also here to talk about successes, exploring innovative partnership, creative programs, modern technologies, and what the future of healthcare will look like in the Commonwealth. This hearing panel provides a variety of hospitals from throughout the state, rural, urban, suburban, to provide a true statewide perspective of the challenges facing our health systems. We would like to thank our panelists for participating in today's hearing and offering their insights on this very important issue. I will turn it over to my fellow chairman for opening comments.
Thank you, Mr. Chairman. And thank you for holding this hearing, and thank you to our testifiers for speaking today during a busy week for the hospital industry. This is an extremely timely hearing for the Commonwealth, and particularly for my constituents in Delaware County. As many are aware, Crozier Health officially closed its doors last week, despite our best efforts to keep the hospitals open and to transfer the system to a responsible operator. Our county has lost its largest employer, and over 2,600 nurses, doctors, and staff now find themselves out of a job. 4 hospitals out of the 6 from the county are now shuttered. They serve a county of over 500,000 Pennsylvania residents. Surrounding hospitals are being overwhelmed by an influx of patients that Crozier and Taylor would have served. Multiple municipalities and the county have declared a state of emergency, given Crozier's role in supporting our EMS system, and we are in crisis management. It's ugly, it's tragic, and it can be prevented from happening in other communities in the Commonwealth. By now, most folks in the healthcare sector know the story of private equity firms like Cerberus Capital Management or Leonard Green and Partners, taking over health systems like Steward Health and Prospect Medical Holdings, and running hospitals such as the Sharon Region Medical Center or the Crozier System. The corporate strategies that destroyed these systems, like leverage buyouts and sale-leaseback agreements, must be addressed by our state, and I trust we will work through legislation to do so shortly. However, I want to recognize that the Wall Street vultures are a symptom of a larger illness within the hospital sector, the illness of financial malnourishment. When hospitals keep running in the red because reimbursement rates don't cover the cost of care, they put off investments that they need to make to survive and to attract more business, from facility maintenance to renovations to workforce investments and safer staffing ratios that boost patient satisfaction. Things get so bad that once you trim all the fat and start consuming the muscle and organ tissues of your business, like obstetrics and other specialties, you have no other choice but to look to get acquired by another health system or by private capital just to survive. It's no wonder that private equity comes swooping in to buy hospitals at a discount, pick the meat off the bones, and leave a skeleton behind. We not only need to protect our hospitals from financial opportunists, we need to address the underlying conditions that are creating this paradigm. I'm eager to hear from our testifiers today and get the full diagnosis of this issue. Thank you. Thank you, Mr. Chairman.
Thank you. Before we get started with our panelists, a few housekeeping items. Those that are on Zoom, and I believe 2 of our panelists are on Zoom, will be muted until it's their time to speak. Each testifier will have 5 minutes to speak, followed by a round of questions after the full panel. Please keep in mind there are a number of testifiers to cover a lot of ground in the next hour or so, so we ask you to keep comments concise. After all the panelists have testified, I'd like to open the floor for discussion with the members of the committee. Also, as a reminder to the members and the panelists, this hearing is being recorded and live streamed. Testimony at the hearing will be recorded and will be available on the committee's website. Committee members that are here today are Senator Brooks, Senator Sanacero, Senator Collette, and some other senators may be coming in and out as there are other committees going on today. The panel will consist of Nicole Stallings, who is the President and CEO of the Hospital and Health System Association of Pennsylvania, also known as HAP. Joining us online is Dr. Mark Rubino, President of Allegheny Health Network, Forbes Hospital, and Allegheny Valley Hospital. Also joining us virtually is Dr. Ed Sabani, President and CEO of the Guthrie Clinic. In person is Catherine Leverins, Vice President of Public Policy and Government Affairs for Temple Health Systems, and also Steve Fontaine, CEO of Penn Highlands Healthcare. Can the members of the panel please raise their hand so that you can be sworn in? Do you swear that the testimony you're about to give is the truth, the whole truth, and nothing but the truth? Please affirm. Thank you. Nicole, we're going to lead off with you. Thank you.
Great. Good morning. Thank you, Chairman Ferry, Chairman Carney, members of the committee. On behalf of our over 235 member hospitals and health systems, it's a pleasure to be with you here today on this critically important topic and very timely issue. You have my written testimony in your packets. I'm going to hit just a few key points and then turn to the hospital leaders that are joining me today from across the Commonwealth who can speak to the myriad challenges that they are facing at a local level and also the things that they're doing to sustain access to care in their communities. My main message today is that the hospital community in Pennsylvania is in a very fragile state, and the solutions to address future hospital closures have to be forward-thinking, they need to be comprehensive, and they need to be sustainable. Hospitals care for us when we are at our most vulnerable and fragile, and now the hospital community is very fragile, and this is the time to change the trajectory of the future of hospitals in our state. You're well aware of the Commonwealth's hospital bankruptcies and service line closures that have been in the headlines so far this year, and the very real threat to access to care in many communities. What's less visible, however, is how close so many other hospitals across the Commonwealth, especially in our rural communities, are to a breaking point. More than half of the Commonwealth's acute care hospitals are operating in the red. Many are facing multi-year operating losses. They are one funding cut, one cyber attack, one nuclear verdict in a med-mal case away from having to make difficult decisions regarding services or, in the worst case, close their doors. When hospital closures are announced, other hospitals in nearby communities are often called upon and expected to step in and ensure that access to care continues. And time again, that's what they've done. That's their mission. The concerning question that we face today is who is going to step in to help the entire hospital field, which is facing profound strain and uncertainty. Especially as hospitals are facing this uncertainty and pressure at the federal level, we need to ensure that we're taking every action possible at home to keep hospitals viable in our communities. Hospitals are vital to the health of our community, serving as community anchors and driving economic activity. They support 1 in every 9 Pennsylvania jobs. They're often the top employers in their communities, and they support nearly 1/5 of the Commonwealth's GDP. And we know that people want to live in communities where they can access emergency care and critical services that they need, like maternal health care. Businesses locate and grow in communities where they have healthy local workforce. Having a strong hospital in a community is a prerequisite to economic development, and conversely, it's easy to see how healthcare deserts can very quickly become economic deserts. And for these reasons, the challenges that we're talking about today aren't just hospital challenges, they are community challenges, because we cannot have healthy, vibrant communities in Pennsylvania without strong, viable, and stable hospitals. From community hospitals to academic medical centers, our community anchors are facing a perfect storm of financial pressures, persistent cost growth, inadequate reimbursement, and shifting care patterns. Hospitals are struggling to maintain access to essential services amid persistent workforce shortages, supply chain disruptions, tariffs, and policy decisions that often fail to reflect on-the-ground realities. My written testimony includes greater detail of the challenges that our hospitals are facing, and I know my panelists will also provide detail, so let me just summarize. In the absence of a public health system in Pennsylvania, hospitals are constantly asked to do more with less. But as the cost of providing care has sharply increased, our community anchors continue to be chronically underpaid by one of their biggest payers, Medicaid. On average, Pennsylvania hospitals are only reimbursed 82 cents for every dollar for care provided to patients covered by Medicaid. And for our rural hospitals, it's even less, 74 cents on the dollar. Pennsylvania's hospital regulations have not been updated since the 1980s, and they do not reflect evolutions in technology and care delivery. And so what this means is the Department of Health is enforcing hospital oversight on a structure of waivers and exemptions with interpretations that vary from region to region. This delays care, and it forces hospitals to employ teams of specialists to navigate ever-changing requirements. Hospitals have teams of employees in place to ensure that they are receiving payment from insurers. Denials, downgrades, and other administrative barriers are becoming increasingly costly to hospitals and detrimental to patients who face delays in cares. Access to care hinges on having a robust workforce, but we're not just focused on meeting the needs of today, but also looking to the future in a Commonwealth that is aging. Despite extraordinary efforts by hospitals to develop, recruit, and retain the healthcare professionals that they need, hospitals across the Commonwealth are seeing double-digit vacancies in every role. Hospitals in Pennsylvania are also facing a medical liability climate that is considered one of the most challenging nationally. Between the threat of nuclear verdicts and the recent Supreme Court rule change allowing venue shopping, our rural hospitals are one lawsuit away from closing their doors. Maternal health deserts are expanding, and fewer independent providers are choosing to stay in Pennsylvania. Each of these policy areas may seem discrete, but in fact, they are important together to the viability of local care delivery. And without appropriate support and evaluation of policy implications, to continue your medical theme, Chairman Carney, hospitals are going to continue to be on life support. So let's talk a bit about some of the solutions that we need. First and foremost, we must ensure that hospital care that is provided is reimbursed at a rate that reflects actual cost. Any other industry would have collapsed by now, facing chronic underpayments that hospitals have to absorb. At the same time, we must take proactive action to address the many factors that are driving up the cost of care and contributing to operational challenges that strain access. We need a consistent and reliable regulatory environment that supports how care is delivered today. The Department of Health is currently going through a rather extensive process of overhauling hospital licensure regulations. It is absolutely critical that the outdated regulations are addressed in a way that supports modern care delivery and encourages rather than hampers innovation. The legislature, we would also ask, not pass legislation that creates additional regulatory burdens that are duplicative or conflict with existing federal or accrediting requirements. We need to grow and keep the number of healthcare providers in Pennsylvania. Bipartisan legislation that passed the House earlier this year and sits with this committee would create a grant program to incentivize nurses, physicians, and others to practice in rural communities. We urge you to quickly advance this legislation that will grow the number of providers where they are needed most. We would urge you to reform Pennsylvania's medical liability climate to keep providers in the Commonwealth, and that starts with collaboration between the General Assembly, the administration, and the courts to reverse the harmful effects of the venue rule change. Finally, we must adopt innovative solutions that strengthen access to care. In the past 2 budget cycles, we've seen specific funding to support rural hospitals, and it's a crucial lifeline. And we appreciate that support, but we also need to find a long-term solution by developing the next generation of sustainable funding because our Pennsylvania rural health model has ended. And we may need to make sure that we're expanding infrastructure to free up our emergency department so that patients can get the right care at the right time. Let's start with bolstering our crisis intervention network to support behavioral health initiatives. HAP and our hospital community stand ready to partner with you on these critically important issues to secure access to care in our communities. Thank you for the opportunity to testify. I look forward to your questions momentarily. I believe it'll be Dr. Rubino next, Mr. Chairman.
Yes, and before we move Dr. Rubino, I just want to recognize Senator Haywood has joined us. So Dr. Rubino.
Good morning, Chairperson Nafari, Minority Chairperson Kearney, and committee members. Thanks for the invitation to speak to you today. My name is Dr. Mark Rubino. I'm an obstetrician gynecologist, and I'm president of AHN Forbes Hospital in Monroeville, Pennsylvania, and AHN Allegheny Valley Hospital in Natrona Heights, Pennsylvania. They're both part of the Allegheny Health Network, which is a 14-hospital health system based in Pittsburgh. We're a mid-sized network with about $5 billion in annual revenue and about 23,000 employees. You know, all the issues that Nicole just mentioned in her testimony affect AHN and my hospitals in one way or another. And as she noted, today's hearing couldn't be more timely. Last week across the state, we experienced some devastating windstorms. Southwestern Pennsylvania was especially hit hard. It was the biggest power outage in the region's history. And it took days for some people to get their electricity back to their homes, and some people are still waiting. At AHN, some of our hospitals were operating on generator power, and really a number of our outpatient facilities were forced to close. And even our communication with employees was difficult. At Allegheny Valley, the situation was even worse somewhat when our local water authority informed us that they couldn't pump water due to the outage, which really resulted in our hospital really having a decreased water supply and really having us to implement our emergency operation procedures. When an event like this happens, it shows you how fragile the healthcare infrastructure really is. You know, everything has to work together perfectly, and when one element goes down, whether it's power, communications, utilities, the entire operation is threatened. Today in healthcare, things are not working perfectly, and our system is truly threatened. And this is why we're having the hearing today. You have my submitted testimony in your packets, but I hope to speak to a few of these threats briefly right now. As I mentioned, I'm president of two hospitals. They're only 13 miles apart. They're both in Allegheny County. But Allegheny Valley Hospital and Forbes are very different hospitals, serving very different populations. Forbes is a regional suburban medical center providing tertiary care services, treating patients with a high case mix index that was built about 50 years ago. Allegheny Valley is a smaller community hospital that's been providing acute care services for more than a century. Despite these differences, they both face many of the same critical challenges, which threaten the affordability, the stability, and the long-term accessibility of healthcare for our communities. These systemic issues are placing unprecedented strain on our hospitals, jeopardizing our ability to serve our mission. As Nicole said, these issues aren't just hospital issues, they're community issues. When hospitals close, it's not just the access to care that disappears. As with many of the former mills in Western Pennsylvania, hospitals are often the largest employers in town. When a hospital disappears, many of them have over the last 3 decades, you know, with really the disappearance of those high-paying, family-sustaining jobs, and the community suffer as a result. Pittsburgh has seen this happen before. So how do we stop this from happening again in our healthcare institutions? First, we have to address the crisis of financial sustainability, or rather, unsustainability. For too long, we've operated under a system that inadequately reimburses us for the essential services we provide. Persistently low Medicare and Medicaid reimbursement rates, coupled with rising operational costs, it creates a perfect storm of financial instability. This is especially true in low growth and no growth areas such as Western Pennsylvania. We've had decades of outmigration, we've had natural population decline, and we have aging populations. And this leads to fewer patients for our hospital, as well as a suboptimal payer mix. This shortfall places a disproportionate burden on hospitals serving rural and vulnerable communities, which is one reason so many hospitals have closed in Western Pennsylvania over the last 3 decades. In just a 10-year period, from 2000 to 2010, 11 of the 39 hospitals serving the greater Pittsburgh region closed. Since then, several more have closed their doors. And just last month, Heritage Valley System announced that it would be closing the Kennedy Township Hospital. So why is this happening? Some of it is tied to the demographics. But on top of that, the cost of maintaining these aging facilities and providing complex care is escalating. The cost of everything from pharmaceuticals to medical supplies to utilities and in insurance and malpractice premiums, they've all skyrocketed in recent years, while our reimbursement has significantly lagged behind. Also, we face burdensome regulations, which also contributes to our industry's predicament. Pennsylvania hospitals operate under a complex web of state and federal regulations, many of which don't match. We have construction mandates and compliance requirements. While we recognize the importance of ensuring patient safety and quality of care, the sheer volume and complexity of these regulations impose significant burdens. We've experienced the weight of these burdens recently in AHN. Just to give you a quick example, historically, hospital-based dialysis rooms haven't been equipped with restrooms because those patients aren't really producing urine and they're limited to their bed while being connected to a dialysis machine. But new hospital building standards recommended by the Facility Guidelines Institute require these new spaces to now be outfitted with restrooms. And because Pennsylvania, like most states, have adopted the FGI guidelines, either we're forced to pay for the unnecessary construction or we're forced to delay our project as we wait for a state waiver, which may allow us to move forward or not. So that's what we're doing at Allegheny Valley Hospital right now, waiting on that state waiver. A similar situation occurs when we're trying to upgrade our urological ORs. The current equipment is outdated, and historically, these OR suites have been smaller due to the nature of the procedure that's being performed in the suites. Current regulations require the size of the room to be significantly enlarged if we elect to install new equipment. Another example, Class II imaging rooms where mammograms are requiring needle localization biopsy. These rooms now also require expansion as well as positive air pressure. This is because what's being defined is the skin is being pierced when there is no clinical difference when compared to a blood draw or a joint aspiration, which is usually performed simply in an exam room. Again, in this case, a hospital would be forced to decide between absorbing the additional expense tied to, frankly, an irrational facility guideline or asking for a waiver, which may take 5 or 6 weeks to come from the state. So maintaining the safe operations of our aging facilities, such as our HVAC systems, our electrical, our plumbing, it requires a tremendous expense as it is. Adding unnecessary costs on top of this makes it difficult for hospitals to make the needed investments in a timely fashion. Often the price tag is driven up so high that it becomes impossible to commit to a project. And finally, I'd just like to briefly touch upon the workforce crisis. I agree with many of the solutions already suggested by Nicole, such as incentivizing clinicians to practice in rural settings and growing the nursing pipeline. Sometimes our industry is accused of crying wolf regarding professional shortages, but as the leader of 2 hospitals, I can tell you the shortages are real and the vacancy rates are high. We're doing our best, but at AHN, we have some hospital units that are empty, not because we lack patient demand, but because we can't staff them. The volume is there, the space is there, but we physically can't accommodate the patients because we don't have the staffing. As you know, COVID-19 pandemic exacerbated this issue. Suddenly, we weren't just competing regionally for nurses, we were competing nationally and internationally against traveling staffing agencies and virtual telenursing companies. Telenursing companies. We were also experiencing significant shortages and competition recruiting a number of physician specialties, especially anesthesia and urology and medical specialties such as nephrology and endocrinology, in addition to our primary care physician shortage. The challenges facing Pennsylvania hospitals are complex, but they're not insurmountable, but we need your help to solve them. As last week showed, we all need to work together. Community taking care of community, local leaders collaborating with our elected officials and our legislators to find solutions that ensure the long-term sustainability of our hospitals and protect access to the quality health care for all Pennsylvanians. Thank you, and I'd be happy to answer any questions you may have.
Thank you, Doctor. Now we'll move to Steve Fontaine.
Thank you. I want to thank members of the committee for allowing me to testify today. It's an honor to be here today on behalf of rural hospitals.
Can you move your mic a little closer? I'm sorry.
Can you hear me okay now?
It's better. Thank you.
All right. It's an honor to be here today on behalf of rural hospitals across the state of Pennsylvania. Our hospitals, especially those in rural communities, are the lifeblood of our local communities and local economies because in many cases, we are the largest employers. We play a significant role in attracting businesses and industries to spur economic development, and without hospitals, many small towns would not exist today. Having a hospital nearby is a sign of community vitality. Let me give you an example. According to Hospital Association in fiscal year 23, Penn Hines Healthcare and its 9 rural hospitals had a total economic benefit to the communities to the tune of $1.9 billion. Over 6,500 employees derive their income from our facilities, and we support families with good paying jobs, and in many cases, great health insurance benefits. I'm here to tell you today that rural hospitals are on the brink of disaster without increased support from state and federal governments. Pennhondas Healthcare was established in 2011 with a mission to maintain and provide community-based medicine in our rural communities. We are a $1 billion integrated system providing a wide range of services through our 9 hospitals, 9 emergency rooms, 150 clinic sites, and a wide array of specialty services ranging from delivering babies all the way to providing care at their nursing homes. We serve approximately 650,000 residents across 26 rural counties in central and southwest Pennsylvania. And in many of these areas, we have some of the oldest populations in the country. This is significant because 71% of our patients, that is 71% of folks who come through our doors every day, are either Medicare or Medicaid recipients. And there are major shortfalls in the reimbursement programs, like Nicole discussed earlier, that are simply not sustainable. Despite these financial pressures, we continue to provide charity care in the tune of approximately $20 million a year for the uninsured and underinsured. Prior to the pandemic, Pennhondas Healthcare traditionally ran an operating margin of roughly 2%, but that has changed dramatically. 3 years post the pandemic, we're operating at a negative 4% operating margin, and as you well know, that is not sustainable. Major components that have driven the negative margins are labor, supplies, and pharmaceutical costs, as we discussed earlier, and we're trying to abate that through revenue growth. Another significant component that contributes to this continued negative margin is inadequate reimbursement. For example, in 2024, by serving the Medicare and Medicaid populations that we are supposed to as part of our mission, we lost $40 million doing that. Pennhondas Healthcare, like other healthcare providers, may not be able to continue to provide all the current services we do today because it's simply not sustainable. For example, we've treated approximately 2,500 patients at our Level 2 Trauma Center since opening in 2023. Our mental health program that includes drug and alcohol treatment, along with 200 inpatient mental health beds, saw over 2,500 admissions last year. And our transportation services that we provide to many of our patients and many of our communities for oncology transportation, for infusion treatments, for mental health patients to get the services they deserve, and for nursing home residents to get to the doctor's offices where they can see specialists and primary care doctors, that's all at risk because we have to make cuts in order to sustain our financials. So how do we resolve this problem? We need to explore innovative reimbursement models to assist rural healthcare providers in continuing to care for the patients. As Nicole discussed, on the table for discussion is the Pennsylvania Rural Health Model that provides potentially cost-based reimbursement for rural healthcare providers or grants that can supplement the programs that I just described. The 340B drug program is a critical component to rural health systems like ours in the state of Pennsylvania. They subsidize access for rural and underserved populations, and we are able to provide services through those revenue streams for the trauma system, for the mental health patients, and the transportation I discussed earlier. But since 2020, pharmaceutical manufacturers have been restricting 340B access and undermining the program's purpose. These restrictions have resulted in approximately $20 million loss in 340B revenue streams for our system, which mimics or explains why we've lost $40 million over the last couple of years. Since that, 20 states in the recent years have passed laws requiring pharmaceutical companies to abide by the HRSA rules to protect 340B access at the state level. This is funding that directly impacts our ability to provide care and to exist long-term. Nicole touched upon earlier the regulatory constraints in the state, so I'll just mention a few. There's tremendous burden when we're trying to implement a new service or implement a new piece of equipment. There are long delays, extensive reviews, and to be honest with you, a lot of red tape. We want to be cognizant of patient safety and quality and outcomes, but I think we need to be mindful of the constraints in the regulatory review. And the other thing that Nicole touched upon, I'll make a comment on, is the payer issues. We employ over 50 individuals, ranging from doctors to nurses to clinicians and case managers, to fight back the payer denials that we face on a daily basis. 30% of all of the claims that are submitted by us are denied in the first time, and we have to staff 50 individuals to get adequate staffing, or rather adequate payments for the services already rendered. In the workforce, it is quite the challenge. We have a vacancy rate of 20% for nursing vacancies. That equates to about 250 nurses or slots we're not able to fill. So we've been proactive. We've been recruiting international nurses, approximately 100 to our system, but that comes with a cost. It's about $50,000 per individual to recruit through immigration fees, legal fees, and the such that we take on the burden of. But we've also done more. We've reached out to community colleges in our communities and say, we'll help you grow your programs. So we provide the nurse practitioners to mentor and teach in those programs to expand the classroom size. And we then also pay the stipends or the full tuition for the students in those programs. Some of those services are nursing degrees, LPN degrees, surgical techs, imaging techs, phlebotomy, and you can go on and on and on. But we are sustaining those burdens because we think that's the mission, and we must fill the vacancies we have in our system. And medical liability. Rural healthcare facilities cannot withstand significant financial shocks that can be experienced with uncapped medical malpractice lawsuits. Tort reform and venue shopping has to be addressed in Pennsylvania. In closing, I want to thank you for your time and attention today. Rural healthcare is facing critical challenges. Our hospitals are not just providers of care, they are lifelines for our communities, anchors of our local economies, and vital support systems for our most vulnerable populations. We urge you to act decisively on the following: increase funding to sustain rural health care, protect and strengthen the 340 pricing program through state-level legislation, advocate for regulatory reforms that streamline processes, reduce administrative burdens, and support innovative care delivery models, invest in workforce developments through targeted scholarships, training programs, and incentives, and support medical liability reform to mitigate the financial risks that disproportionately affect rural providers. Again, thank you for your time and your support.
We are joined by Senator Robinson, so thank you for joining us. We'll turn it over to Ms. Levens next.
Good morning, members of the committee. Thank you for allowing me to speak with you here. Can you hear it?
Pull a little closer.
Thank you for allowing me to speak with you today. I'm not going to repeat a lot of what you've already heard. I'm in complete agreement. I'm just going to speak from perhaps a different lens. I'm the Vice President for Public Policy and Government Affairs for Temple University Health System. My voyage with Temple Health began when I was a volunteer member of a community hospital, the original St. Mary's Hospital in Fishtown, which became Newman Medical Center, which closed. Went through a lot of changes in that area, and I've been with Temple through a lot of those community-based changes and reorganization of a number of hospitals in North Philadelphia and the River Wards and the lower Northeast. Most of you are familiar with Temple Health, but just a quick snapshot, we have 3 hospitals. The most known to you is probably Temple University Hospital, which is an 879-bed hospital with a trauma center, verified burn center, located in North Philadelphia. About 44% or so are covered by Medicaid, additional 42% Medicare, so we're about 86% government pay. Part of that system is our Episcopal campus, which is located in Kensington. It's a bit notorious neighborhood for the open-air drug market. Our Episcopal campus has responded to the community needs in that area. We continue to respond. It's always changing. But when another health system might have closed that, said we can't make a business case out of it, we opened a new substance use disorder clinic. We are about to open a brand new crisis response center, more than triple in size of our current one, and we doubled the size of our emergency department. We work with the City of Philadelphia, the police department, and a lot of other partners to make sure that that's a successful operation. We also have on the campus, which is one city block, 2 housing programs, one with Sister Mary Scullion's Project Home, and another is an opioid respite center with the city of Philadelphia, constantly changing to the community needs, and we're quite proud of what we do there. We're about to open a new hospital for women nearby. More to come on that one, but both our behavioral health and our maternity are about 85% Medicaid. Nobody else is making that type of an investment in women's health and behavioral health in Philadelphia. We also have Fox Chase Cancer Center, which is a designated NCI comprehensive cancer center located in the Northeast. And finally, we have Chestnut Hill Hospital, which I'm very proud of, Senator Haywood. I was asked to talk about some of our partnerships. I think that is a complete classic, successful partnership. About 3 years ago, there was talk about a potential closure. Chestnut Hill was owned by a different owner, and we came together with Holy Redeemer Hospital and the Philadelphia College of Osteopathic Medicine, and we formed a partnership. Temple is a 60% owner, and we operate the hospital. We've made a number of investments in it. We're 2 years into it, and it's on the move. And I want to thank Senator Haywood for his support throughout this process, not just for Temple Health System, but for his commitment to the communities. So the topic of this was sustainability. I think it's pretty basic. You know, to be sustainable at the outset, a hospital has to be committed. You have to have committed leadership, committed board. You have to have clinical excellence. You have to be innovative, not just in adapting scientific breakthroughs, but as we just talked about, adapting to your community's health needs. Valuing the partnerships, I just spoke about one with Chestnut Hill. Another innovative partnership is one that deals with WellSpan, which is in, as you know, South Central Pennsylvania. We will be opening a medical school campus there in 2027. Plans are all in the works. We work closely with WellSpan, not just, I just spent 2 days with my partner at WellSpan at the federal level working on issues, but this is a campus that we think is going to not only help strengthen the WellSpan system, but help build the physician workforce in the rural areas. We opened a similar campus about 15 years ago in collaboration with St. Luke's in Bethlehem, Pennsylvania. I'm sure this is going to come up, but we'll talk about funding. It's clear that in order to do these type of programs, you need fair and adequate reimbursement. And Senator Carney, I think this has not been more apparent than what you are and your constituents are dealing with in Delaware County. We're pretty distant from them, but we're doing what we can to help your constituents. And I think that a number of us in southeastern Pennsylvania are all doing what we can, and it's something that we're just going to have to continue to work through. Pretty noble what your employers are going through right now. I'll just close with 2 things that haven't been mentioned. Well, actually, one was the delays and denials by the Medicaid MCOs. That would be something I would think that we could strengthen the partnerships with our insurers and our health plans, because some of the practices on that end do affect our financial stability. It was already been mentioned, the delays and denials. I am just going to mention that this is particularly apparent to us with our cancer population, and it's in my written testimony. There's some data, I won't go through it, but where these delays and denials, are ultimately overturned once you get the physician to physician. So why was it all held up to begin with if they're ultimately going to be overturned? So that is something that I think can be looked at. And another is what we call a hospital freeze. And what that is, it's best to illustrate it. is suppose you have a patient who you're trying to discharge. It's Thursday afternoon. You get in touch with the health plan. The health plan doesn't get back to you on Friday. They're closed all through the weekend. Monday, assuming there's not a holiday, which would be Tuesday, you finally get this approved. In the meantime, you have, and this, particularly over the winter with what we saw with the respiratory illnesses, you have people who are backed up in the emergency room. You have people who are, hospitals are filled to capacity, and you can't get somebody in a bed because you cannot get somebody out of the bed. And so through the weekend, the hospital is providing those services and resources that are better, for example, in a skilled nursing facility. We're paid, on a single payment. We incur the costs while the insurers save the money. So I think that that's something that could be looked at. That completes my statement, and happy to answer any questions that you might have.
Thank you. We'll move to our final panelist, Dr. Sabani, President and CEO of the Guthrie Clinic.
Well, on behalf of the Guthrie Clinic, I'd like to thank Chairman Ferry, Chairman Kearney, and the committee for allowing me to speak at today's hearing. It's an honor to join you, and it's a very critical and timely topic. My name is Dr. Ed Sabani. I'm a surgeon by background, and I'm the president and CEO of Guthrie, which is a nonprofit integrated clinical health system serving patients across northern Pennsylvania and the southern tier of New York. The system dates back 115 years. Just from a size perspective, we have about 10,000 employees across our rural network of 6 hospitals and more than 75 clinics. We have 1,000 providers that work in our system. We deliver care to hundreds of thousands of rural residents each year and have 1.6 million visits annually of those patients. I believe my colleagues have shared strong points regarding their financial situations, which we share at Guthrie. Ours is a clinically integrated system across the spectrum, from acute hospitals, rehabilitation centers, home health efforts, outpatient ambulatory surgery centers. We cover 10,000 square miles. In that area, we are usually the only significant tertiary care that they may have an opportunity to receive. We are, in all of those communities, the largest employer. We certainly share the economic challenges that were addressed earlier as a rural hospital system last year. We had an audited, validated $132 million in uncompensated and charity care. We're proud to serve this population. 70% of our population is Medicaid and Medicare, but the sustainability is challenging. We see there are 3 areas that I would like to discuss, both from a challenge and opportunity perspective. But before I do, the one thing I haven't heard perhaps is, what is the burden on our rural patients by the challenges that we see in healthcare? Well, the Department of Agriculture's Economic Research Service reported that the natural cause mortality for working age people in rural areas was 43% higher than that mortality of similar patients, similar age, in urban areas. 20 years earlier, that gap was only 6%. So that's the challenge that we're facing, is folks with the same conditions in rural areas are potentially dying at higher rates than those in urban areas. So what are our 3 areas of challenge? First, workforce. We, like other health systems in the state and across the country, experience a workforce shortage. The Commonwealth, I've seen projections of 20,000 nurses short. What does that mean for us? As an operating surgeon, I will be in an operating room at Guthrie, and I may be working with a temporary labor, very skilled nurse, but a temporary labor nurse. And what that means is they're working side by side with someone who may be making half of the salary that they are making as a permanent employee. As you can imagine, from an economic sustainability viewpoint, that is a huge challenge. While we offer competitive pay and generous benefits, we face the same recruitment and retention challenges that are common to rural systems, due often to geographic isolation. As legislators, we would ask for you to support programs and policies that make recruitment in these regions to build and maintain our workforce easier. Guthrie joins HAP and others in strongly supporting House Bill 157, which would establish the Rural Healthcare Grant Program. Through incentivizing healthcare professionals to work in rural communities, this bill would address a key barrier to recruitment and retention, and that is student loan debt. And we would really advocate for that. While recruiting healthcare workers from outside rural communities is essential, I think, to meet the immediate needs, it is equally important to keep local talent home and build relationships from within. We support legislative efforts that would strengthen and expand rural healthcare workforce pipelines, whether it's school-aged programs or college programs. Building a qualified and sustainable workforce requires an investment and engagement at every level, in the states, and the Commonwealth's help will be very much appreciated. The second thing I think we need to address is we need to think differently and innovatively about clinical care delivery. We may not, in rural areas, ever, at least in the foreseeable future, have the complete degree of talent that we want to service our needs. But we've got to embrace creative thinking and implement innovative solutions. For us at Guthrie, in 2023, we opened what we have called our Pulse Center, which has now been nationally recognized as a transformative model. It functions like a command center, and it involves remote healthcare professionals who are utilizing real-time monitoring, data analytics, artificial intelligence assistance, and two-way communication to enhance both bedside and home care to improve patient outcomes. We've extended that clinical reach without replacing bedside staff, and that's very important. This program is a safety net and a support for the bedside staff, but it does not replace. These new models, I think, have the potential to enhance access, to improve efficiency and safety and outcomes. However, for them to succeed, they must not only be supported, but they must be scaled thoughtfully and carefully through reliable investment. At the Guthrie Clinic, this was an initial investment of almost $26 million. And it has shown a lot of payoffs for us in care quality. In our 10,000 square mile area, we are now the only Leapfrog A or B hospitals in the entire region. And these sort of programs have, and as you know, Leapfrog is a safety score, and these have allowed us to have that sort of result. As importantly, it allows us to discharge patients home with a safety network around them that will free up our crowded hospitals and yet get people to where they want to be as patients, which is home. The third thing that I would mention is we would relish regulatory relief. As others have indicated, this is an important efficiency to allow us to be innovative. As legislators look to improve healthcare quality, I would suggest that models such as the Pulse Center be protected and guidelines be established so that every patient receives quality care from trained professionals, whether in person or virtual. We do not want to see patient safety compromised or quality compromised by a lack of training or credentials, and we don't want to see virtual services replace bedside resources. As a rural health system serving communities across Pennsylvania, we also strongly support the Rural Emergency Health, REH program, as a critical step to preserving access to life-saving care in underserved areas. Due to low volumes and high operational costs, many rural hospitals across the state, as you know, struggle to maintain full inpatient services. The rural emergency hospital model allows facilities to keep critical services such as emergency stabilization and outpatient care while receiving enhanced Medicare reimbursement and financial support. We would really appreciate the Commonwealth's consideration of that program. It is a privilege to speak to you today. I really appreciate your important work, and my team and I relish the opportunity to answer any questions you may have.
Thank you to all of the panelists. We will move on to questions from our senators. We'll begin with Senator Haywood, followed by Senator Collette.
So thank you so much. This has been a fantastic presentation. Very, very much appreciated. In December of 2019, I had a hearing in my district of hospitals, Penn, Jefferson, Temple, and others. And the topic was reimagining hospital care, reimagining hospital care. And that was in December. Of course, unfortunately, a few months later, we're hit by the COVID crisis, so the whole reimagining kind of thing was shocked. And I'm hearing some of aspects of reimagining, the Pulse example and some of these other examples which I think are critical. The question I have is this. With the Medicaid and Medicare reimbursement challenge, how much will having more staffing help the hospitals to address that challenge? And I raise it in the context of we send more people to be workers that are desperately needed, and then on the other hand, the hospital can't make it because of the reimbursement rates. So we certainly don't want to create a situation where we're sending our young people or older people into environments where they're going to close. And that would be like a bad public policy. So I am concerned about that conflict. We send people through the grant program, but yet there's a private equity firm that buys it and then closes it. So be interesting to hear your response to that challenge.
Thank you, Senator. And I think you're raising a critical point here, and that's how interrelated all of these issues are. That said, when I first took this role just under 2 years ago and was meeting with hospitals across the Commonwealth and asking, what is your top challenge? Workforce consistently came to the top, and we've cited some statistics about vacancy rates, but also what we will need year over year into the future to address shortfalls. With respect to rural communities and why we are so supportive of legislation, we know that when you invest in putting someone in a rural community and you provide loan repayment, they stay there. They stay in those communities, they put down roots. It's an over 80% return in particular for physicians. So we know this is a tested tool. We also know that when we are looking at the financial stability of hospitals, inflation, including labor inflation, is one of the biggest drivers. Our hospitals have been throwing everything they can at the workforce shortages, from permanent pay increases to bonuses to investing in childcare at rates higher than employers elsewhere to keep and retain staff that they need in those areas. And so I don't think you can talk about one without the other. We need the workforce to continue to build up financial sustainability. But of course, we're very mindful of the stability of our hospitals and the ability to keep those workers in place, critically linked. And I'm not sure if others on the panel would like to add anything there. Thank you, Senator.
You know, I might just add from, I think, most of the hospital's viewpoint, temporary labor costs typically twice as much as non-temporary. So the clear payoff to getting permanent employees and getting us fully staffed is economic, as well as teamwork, cultural integration, et cetera. So, you know, this will pay off economically if we can figure out the workforce and lower our temporary labor. We will be more sustainable just from that action.
Yeah, and if I could just add as well, I agree with Dr. Stabenite. The other thing is we have retirements occurring. We've had a workforce now that is aged, and we have a lot of nurses now that have got us through the pandemic, and they're at that point of their career where they're leaving us, and we don't necessarily have the backfill. So we really are dependent upon those new nurses coming into the system to fill that gap.
Senator Haywood, one final comment on that, more practical from my standpoint, is what we face is access issues. Today, in the state of Pennsylvania, across the nation, when somebody wants to see a specialist of some kind, Unless you know somebody, you typically are told you have to wait 3, 4, 5 months. Sometimes that's because you don't have enough doctors, but oftentimes you don't have enough nurses, techs, or front-end staff that you think are easy to come by, but they are not. Most people do not want to work in that environment anymore when you can go down the road and work at Sheets, for example, for $20 an hour, as opposed to the grind of working in an office. So I think, to add to everybody on the committee what they said already, that's the more practical sense of why you need more people in the healthcare to address just basic clinic visits who then get procedures down the road.
Yeah, I would just add to that, the local workforce. Agree with everything that was said about the nursing and the physicians, but I think we all also have a responsibility to the local workforce. We have at Temple Hospital each year about 2,300 learners, whether they're nurses, physicians, or laboratory techs, pharmacy, podiatry. There's a whole host coming through the hospital getting training. We work also with about 65 different partners, community hospitals, Holy Family Academy, other small colleges and universities, and also training programs for the local workforce. And I think that it's sad to see when a hospital does have to close, but I think at least getting the training that you can get in a hospital and the exposure to some of the jobs that like a young person might not be aware of, like a pharmacy tech. So we're trying to get residents of our local community through high schools and other programs in to get that training. I hope to be around for a long time, but if a hospital closes, or even if that person wants to move up and go to another health system after they get training, I look at that as being a success.
Thank you. Senator Collette, followed by Senator Brooks.
Thank you, Chairman Ferry and Chairman Carney, for convening us here, and thank you to our panelists for your presentations today. Many of you may know that I am a nurse, worked at the bedside in an acute care hospital, and so I have a big network of nurses that come and talk to me about what it's like in the workforce today. And I will tell you that a lot of them are talking to me about why they do not want to be at the bedside. And it has to do with burdensome staffing levels, too many patients per nurse. There are hospitals that aren't paying nurses at market rate. And so my question for our operators here in the hospitals, what is the hospital's plan to incentivize nurses to work at the bedside? Because I have introduced the Patient Safety Act year over year. It passed through our House last year. I know that, it's something that we have to talk about because the nurses that I speak to are telling me that this is one of the biggest barriers to them wanting to stay at the bedside and continue working. And so what are hospitals' ideas for incentivizing nurses when it comes to that burdensome, patient to nurse ratio that they're experiencing right now?
Maybe I could get us started. Senator Collette, I think you raised a very important question, and it's very timely today as one of the Nurses Week, and we just left a celebration downstairs for that. We have to do a better job of engaging them, not just in financial means. I think we are, as an organization for Guthrie, we are market competitive now. But to your point, folks still are burning out with bedside care, and one of the ways we have mitigated that in the past 2 years is this Pulse Center, which has a virtual nursing component, which means, if you will, it's a phone a friend. It's the ability for someone 24/7 to reach out and literally by camera, they're in the room, they see the specifics of the care, they're sharing an EMR, and they're helping the nurse. We have received a number of positives from our folks, and it's extending careers. Our retention rates have never been higher for nurses since we started doing this. One of the things that I think about is if I was trying to, first time I'm a newly licensed nurse and I'm hanging a heparin drip at 2 a.m. and I'm all alone, that's not a good place. And we have found that this sort of initiative has helped us greatly for that issue.
Just to build on those comments, we also use a digital nursing platform, and we've tried to do is address the documentation challenges of nurses. You know, that whole admission and discharge process is really extensive now. So what we have done is we use also cameras in the room connected to their televisions. And we've taken those nurses that are at the end of their career that maybe just can't do it anymore on the floor, but have that wisdom. And we allow them to connect with our patients to aid our floor nurses with their admissions, as well as take the time to do the discharges. They also actually do hourly rounding on the patients, and they could spend time, a lot more time with the patient for that discharge process to make sure that they understand their medications. We could also connect with a family member that maybe is out of town, and they can share in that visual, you know, it's almost like a Zoom like we're having here today. And it's actually been a very much a nursing satisfier. We're using the technology now to this advantage, and we've made that investment. And I agree exactly what was just those comments, in that we need to look at those innovative approaches to be able to take some of this burden off of nurses. And the only other thing I would speak to is that, you know, the majority of workplace violence that occurs in our country occurs in our hospitals. And we've had to invest in just crisis management teams, right, to address those patients that are acting out. You know, we do have substance abuse issues, and we have people that maybe are coming down off of that addiction, and they're lashing out. And often the nurse that is there to try to help them are the ones that get hurt. So we appreciate the efforts that we know the Commonwealth are doing, as well as, you know, even some of the federal legislation that's looking to really address this issue, but is really a very important issue that needs to be recognized.
I would mention one more thing to echo what the other CEOs stated, is that it's all about the team concept model. So the nurse needs a team of other professionals to take care of those patients. And that's a pretty basic model, but the problem is you can't find enough CNA, certified nursing assistants, or patient care techs. And so what we've done, develop training programs within our health systems that last 2 to 3 months, so they're certified, and then they can join the workforce. We pay for that tuition and training for those 3 months, and then we integrate them into the team model concept. And just from a career development for our nurses, we offer the 2-year nurses to advance to their 4-year degrees, and we pay for that tuition. And if they want to advance further and get their master's so they could become nurse practitioners, we pay for that as well, so they stay within our system. So it's been really a real success story for our system.
Perhaps first, Happy Nurses Week. Nurses truly are the heartbeat of our healthcare workforce. I think what you've just heard are examples of the ways in which our hospitals are trying to address this problem, from new programs to supports that they provide to changes in care delivery. I will restate a point that I made earlier. We really need to evaluate the policies that are in place in other areas that are impacting this. So we know that there are staffing requirements in our nursing homes. We know that our nursing homes have not been able to hire enough staff to keep their beds open. That was why, for the first time this year, we issued our workforce report in partnership with the nursing home industry to demonstrate the ways in which our staffing shortages are impacting access to care. And when we have staff that are in our inpatient, or excuse me, when we have patients that are in our inpatient beds for too long, waiting to go to a nursing home, days, sometimes over a week, oftentimes to nursing homes that are further away, which is impacting their family's ability to come and care for them, that's also incredibly frustrating to our nurses and the capacity that we have within our hospitals. So it's critically important, I believe, to look at the way that these policies interact and are driving some of these challenges too.
Thank you. And, you know, I really appreciate those responses. And I think one of the concerns that, you know, I always had as a nurse when working in the care team model was that no matter how many CNAs on the floor, it was my license that was jeopardized if something went wrong with that patient's care. And so while I appreciate that, I do want us to be open to the ideas that in ensuring that as acuity gets, you know, patients are just getting sicker and sicker. We have a high aging population with significant comorbidities, and as those people enter our hospital systems and require care, then it just requires more of the nurse. And so we want to make sure that those people who are the lifeblood of our care teams really are able to provide the care that they strive to. I wanted to just build off of something that Dr. Rubino was talking about with regard to violence in the workplace. And yesterday, the House passed a bill that would ensure that nursing professionals have a seat at the table to develop workplace violence prevention plans. Because I think one of the issues that we have is that the plans that are in place are not currently working as effectively as we need them to. I, myself as a nurse, was the victim of workplace violence, and so this is something that's very near and dear to me. It's something that I really think we need to do a better job of understanding why that lends to frustration from our nursing professionals. They want to feel safe in their workplace. They want to feel empowered to provide care, even to difficult patients, even to patients that are experiencing, whether it's a behavioral health issue, a substance abuse issue, whether it's a medication reaction, whatever it might be that's causing that patient to be difficult to work with. They want to provide good care to that patient. And so I really do urge our hospital systems to support that legislation, because in the absence of that getting to the governor's desk for a signature, we are sort of just doing piecemeal here to ensure that nurses across our Commonwealth are free from workplace violence when it comes to patient care. So I just want to sort of reinforce that that is a big issue. And thank you, Dr. Rubino, for raising that. Thank you, Chairman.
Thank you. Senator Brooks, followed by Senator Sanacero, and we do begin session at 11, so I just want to make sure we can get through all the senators that have questions.
Thank you, Mr. Chairman. And I appreciate the testifiers on the panel for talking about some of the creative ways that you are trying to embrace your helping your nurses. I share your concern with unintended consequences of, some pieces of legislation that perhaps can take beds offline and actually create or exacerbate the problems we're already having, especially in rural Pennsylvania, where we don't have enough beds. And, I was just talking to Zach Schamberg yesterday in regard to what the nursing homes are struggling with, that now we are seeing our loved ones have to travel or go out 2 or 3 counties to a nursing home to visit, a grandparent, a mother, a father. So I do appreciate the creative ways that you're trying to help our nurses, because they truly are part of the front line of our healthcare. I do have a few questions. Dr. Rubino, you had mentioned the FGI guidelines.
Sure.
Can you talk a little bit about the opportunity that hospitals had to weigh in on the impact of these FGI guidelines and adopting them?
I know that there are now sessions, really addressing the fact that the regulations are going to be updated that haven't been updated in Pennsylvania for quite some time. Most of our hospitals have been in these communities for years, and they just require new equipment. They require, we're looking to drive efficiencies of care. And the challenge is that we're faced with the fact that some of the guidelines that exist are high standards that we would all like to obtain at times, but sometimes they just don't make clinical sense. And that's the reason that I mentioned them this morning. So the opportunity is that once we kind of identify something that just doesn't make sense, like we've been doing mammographic biopsies in the rooms for years. The new equipment now, the 3D imaging machines, costs on order of like $200,000 plus. And then suddenly we go to put that in there and we submit the design. They say, well, the room's not big enough. Well, we've been working in that room for years. Well, you're going to have to expand it. Well, we can't. There's no room to move. So what do we do? So, well, we request a waiver and we wait. So it's a waiver process right now. And sometimes you get approval at one hospital and you may not get approval at another. So you have to appeal it. And it's just a burdensome, and it just drives up costs. The cost of doing anything now from a construction basis have just risen substantially. And you get to a point where you just say, well, hey, we can't do it. We just can't do it this year. We're going to have to wait. So those are the challenges that we face right now. And I think that there just needs to be a flexibility in the system and weighing the clinical impact. These urology suites in all our hospitals, and I'm sure everyone could agree to this, they have this historic setup where they have these fixed imaging systems. And the rooms are smaller because of the nature of the procedures. But if you want to change that equipment now, you got to expand the room. And that's literally probably another $300,000 to $500,000 in addition to the equipment. And you say, okay, well, we can't do it this year, and it's those type of things that we're facing. I hope I answered your question.
Thank you very much, Nicole. Could I ask also the opportunity that the hospitals or yourselves had to weigh in on whether it was prudent to adopt these regulations?
Sure. I think overall, my understanding of the history here, often our hospitals are not seeing specific language when concepts are being described. And so we very much would support a very robust stakeholder engagement process. I'm recalling, I was sitting beside Mr. Fontaine at Mon Valley, and Senator Brooks, you were there at a Senate Policy Committee meeting, and you asked specifically about regulations that would be supportive of our rural communities in particular. So 15 months ago, we submitted a list of 15 things to the Department of Health that could be supportive of our rural hospitals, and 15 months later, we're still waiting.
Thank you very much for that. I was assured, as chair of the Health and Human Service Committee, I was assured by the departments that when they were implementing regulations, that they would have the stakeholders at the tables, the people that are in the trenches at the table. So I will try to help address that. And I do have several questions, but I know we're limited on time. My district is a very rural district, as many of you know, and I'm very concerned about maternal care and the loss of maternity units and the care deserts. Do any of you have any ideas on how to restore OB services in the more rural areas? You know, we have people driving 45 minutes to an hour to deliver a baby. And I know that we talked about, what some call venue shopping, but in addition to that, what other suggestions may you have?
One of the things we've done is we now have mobile maternity vans that go out to provide into the rural areas to provide for the most needy who have social drivers of health. They cannot come to our facilities. So I think being out and about is very important for both prenatal, post-delivery depression screening and other things. So we're doing that. I think the venue, we have 4 different sites that deliver, and we're proud to do it. From the economic viewpoint, it is especially, in the for-profit world, this is not an area that makes money for that, but we are proud to do that service. I think the litigious issues around maternity care may make this discussion hard in terms of it can be quite an economic burden for a health system, and perhaps that's why some have gotten out of it. But we've tried to be innovative and reach out to our patients.
So for the sake of saving time, if any of you have any further ideas, if you could send them to my office. I know that, the state Supreme Court ruling most certainly did not help this issue. So I would be interested on how we can assure that families living in rural Pennsylvania don't have to drive an hour to deliver a baby. And I will wrap up with, this should be a very quick question. In COVID, we did put a waiver system in place, and many of those waivers worked. Are there waivers that expired that you would like to bring back on a permanent basis? If so, if you could send them to my office, I would appreciate it. Sure. Thank you, Mr. Chairman.
All right, Senator Sanacero, followed by Chairman Carney.
Thank you, Mr. Chairman. I'll try to be as brief as possible. First of all, I want to thank all the witnesses for being in front of us today. Obviously, reimbursement is a big issue. You identified that as one of the top issues that each of you has faced. My question is not so much on the reimbursement rate. We know that's a problem, but with respect to the initial denial of claims, because we heard that you have to put a lot of resources into fighting those. What's, if you could, in general terms, give us a percentage of what those initial denials are, and among those that are initially denied, what the percentage of claims that are ultimately then accepted or when those denials are reversed?
Yes, and it's in my written testimony, but at least I have some data with respect to the cancer. I'm trying to find it here. So at Temple Hospital, this related to the Medicaid MCOs, about 40% of the imaging tests for cancer patients, although such measures were standard of care, around 80% of initial denials for imaging care overturned after appeals involving our nurses or physicians, indicating that these tests should not have been denied initially. Similarly, over 10% of chemotherapy treatments are initially denied by MCOs, but about 85% of those denials are overturned after consultations between physicians. So that's with respect to the cancer care.
I would say, Senator, I stated earlier that 30% of all of our claims are denied initially. Some payers are better than others, of course, but to the committee member's point, they particularly go after admissions to the hospital, which are costly, and then procedure-based. In her case, cancer would be one of the more costly procedures we perform, so they're going to outright deny a lot of those and force you to provide egregious amounts of documentation to support what you're doing. So it's more procedure-based and inpatient, because that's the bulk of the money they allot to the hospitals upon the proper documentation.
And at what percentage of time are those denials then reversed? Do we have that information? Do you have a sense of that?
I will survey our field and get this information back to you. I'll note I have a data point in my testimony as well. More than half of hospitals nationally report more than $110 million in unpaid or delayed claims that are at least 6 months old. I had a board. I have a board member who I spent several days with in Washington, D.C., and she told me that for their small system, they have over 300 employees that are just working on prior authorization. So imagine where we could deploy those staff in the delivery of care versus fighting down things for our patients and payment that is due to us.
Okay. Thank you. Thank you, Mr. Chairman.
Thank you, Mr. Chairman. Thank you all very much for this. It's really been a great hearing, I think, in terms of the amount of information and the variety of variety of sources for that information. I really do appreciate it. I wonder, Ms. Stallings, given the precarious state of Pennsylvania hospitals, do you expect more mergers and acquisition activity in the future? And do you think we will see more or less interest from private equity-backed companies in taking over hospitals?
Becker's article just a few months ago said that Pennsylvania was the hotbed for merger and acquisition activity in the country. I talked a lot in my testimony earlier about the headwinds that our hospitals are facing. We know that we're now seeing more consolidations than we are closures. I do expect, Senator, that there will be additional transactions that are being contemplated in the near future, perhaps not at the same rate as we've seen most recently, but given these headwinds, and in particular the uncertainty in Washington, D.C. and that funding, I think our hospitals will continue to be very strained.
Okay, I appreciate that. We often hear the need to allow private equity into different distressed industries because we need to attract investment in order to get these industries back to solvency. But there's no mechanism to ensure that private equity-backed companies actually fulfill the promises that they make when acquiring hospitals. Certainly in Delco, we tried to enforce Medical Prospect Holdings' 2016 asset purchase agreement in court several times, but none of their contractual obligations or verbal promises mattered in the face of their debt-financed shareholder dividends and real estate sale leaseback debt. It's clear to all that the closure of Crozier is now creating a major financial and operational problems for all of the hospitals surrounding us. So I ask each of you, is private equity good for the hospital sector? And if the answer is it depends, then shouldn't the policy to distinguish between valid and invalid private equity interventions?
I'll jump in here. We've had extensive conversation around the HAP board table about this very topic. What I can say is that we believe that private equity does have a role in healthcare, and we need private investments at times to protect and improve access to care. With respect to policies that may be put forward to address what we've seen recently, what I can commit is the HAP team will sit down and very thoughtfully and meaningfully engage in any proposals that are put forward, because our number one goal is to ensure continued access to care in communities.
Okay. Thank you. Anybody else?
Senator, the only thing I would comment on is that, I think that recognizing the networks that are occurring in Pennsylvania is important. When I look at just the, I'm a president of 2 hospitals. I have a hospital that financially would not survive on its own, Allegheny Valley, just because of its operating margin, because it doesn't offer the full breadth of services. It's one of the typical community hospitals that once those specialists retired, it's almost impossible to recruit another vascular surgeon, another thoracic surgeon, and things like that. So to work independently is very difficult, but to work in concert with another hospital, again, to have your own regulatory person, safety person, quality person, we share those over our hospitals now, and that cuts down the cost. So I got 1 CFO, 1 safety officer, 1 quality officer. In fact, we even work together now, not only administratively, but clinically, that we can move patients back and forth. And those are the powers of the networks that exist, that I'm sure at Guthrie and at AHN and the other networks. So recognizing that and being able to identify the network aspect of our systems is going to be important for the state, because it's really now not recognized in a way. We still, even though we report out, we do that independently through our provider numbers as independent hospitals. But there's a lot there that is really going to drive the efficiencies and the value of care.
If I might add one final comment is, most of the counties in which we serve have populations from 30 to 40,000, most of our counties. And if you're looking at private equity firms, not to bash them, but that's not enough population to justify capital investments and to get enough volume out of it to justify returns on investment for procedures or other things they're interested in. So to Mark's point, we operate 9 rural hospitals in small counties, and the way we make that work is we have a tertiary hub, and that's in Du Bois, and we provide all the subspecialty care, subspecialized care at that one center, so that referrals are sent in from other counties with minimal travel. If we were to go bankrupt or go under, there are not going to be many private equity institutions interested in that small population when they can go to much bigger growing populations to get a quicker return on investment. So just be mindful of that when we're looking at investments and sustainability of rural health systems, that we're critical to providing those key services in small counties that oftentimes are overlooked by much bigger counties or much bigger populations.
I would agree with that, and I appreciate that sentiment. I mean, I think rural hospitals in a lot of ways, though, are sort of ripe pickings almost for a lot of the private equity in the way that they work, in terms of hospitals that are on the margins, hospitals that their margins are so tiny. The fact that we have Delaware County has 570,000 people live in Delco, and the system operated with 4 hospitals, all 4 of which are now closed. So it's I appreciate where you're coming from, but I think we really do. It's incumbent upon us here in Harrisburg to literally put our foot down about some of this stuff and try to figure out where those lines are and where those limits need to occur. So it's
If I could just make a comment, I mean, we took over a facility that a private equity had exited in Tunkhannock, and I think that we need to put guardrails around these sort of actions because healthcare is not a transitory commitment to a community that is profit driven. That is not a sustainable model for that community, and we have seen it over and over again. And I think we have to stay very vigilant, on this. And I think the legislative approach is going to be very important.
thank you, Doctor. Catherine?
Yeah, and I would agree. Right now, in southeast Pennsylvania, we're all thinking about Crozier, but it wasn't too long ago that we had the Hahnemann closure and St. Christopher's Hospital for Children. With respect to Hahnemann, fortunately, there was Temple, Penn, Jeff kind of flanking it, so we were able to absorb those patients. St. Chris wasn't in the same position, so for the past several years, we've had Temple and other providers pitching in about $5 million a year, try to keep it open. It's now part of the Philadelphia Hospital assessment, fortunately, so that's a big, really important for St. Chris as far as its future sustainability. But I do think that if there could be some other level of review, I would have liked to have thought that Hahnemann and St. Chris would have been the last, and
Yeah, we're
not. And I think Crozier's in a different situation. You're not, and that's the sadness about it, is that there's not a whole lot of providers immediately around that can absorb a patient population that has limited transportation and other barriers.
Yeah, obviously, we do have all those issues, and it's, I mean, I do appreciate that. I mean, the fact is that here in Harrisburg, we're not always good at learning the lessons from things and acting on them in a way that really kind of makes sense. There were lessons from Hahnemann that we should have learned, and things that we could have done, which we haven't done. And that puts us in a situation kind of where we are, at least in Delco. But I've taken up too much time. I want to give it back to the chairman to finish this up.
If you want to ask some more questions, it's fine with what you have going on at home. So I'm not going to ask any questions. I know there may be some other senators that have some questions, and Senator Brooks has some follow-up, and I think Senator Haywood have some follow-up. So we're happy to get all that together and send it to you in one package, and then we can circulate it all back to the committee. But I do want to thank our panelists for being here, and being online. I think this was a very constructive and open conversation, on some of the things we need to do to help the survivability of our health systems, as well as, try and avoid what has happened in Delaware County from happening again. So we look forward to seeing what we can do to help with your sustainability. I mean, it sounds like it's across the spectrum from workforce to financial to regulatory and bureaucratic. And that's not a recipe for success. You're not pointing to one single problem. You're pointing to multiple problems. And we have grave concerns for our rural areas, but then you see hospitals closing in Philadelphia and in large suburban counties as well. And I think that is very problematic. So I do want to thank you all for participating today. And we look forward to further feedback on how we can help and ensure that we have a robust hospital system throughout this Commonwealth. So this will conclude today's hearing of the Senate Institutional Sustainability and Innovation Committee, and we will stand in recess until call of the chair. Thank you.
Thank you.